Hello, Titani nerds. Welcome back to the next episode of the Dental Implant Podcast. Again, it's late in an evening. It's nearly 20 past 8, and I'm delighted to have a colleague with us today, Dr. Balaji, who's known for his grafting skills. I remember a couple of years ago, we both lectured at the ADI, didn't we? And I had a few people in there, some big names in there, and I was quite happy. When it was time for your lecture, mate, the place was rammed. There was people literally lined up down the hall. And I remember looking at your cases and thinking, this is absolutely exquisite work. And we're going to hopefully give people some insight into a lot of things today. But what I would like to do is just give us a brief introduction to yourself, my friend. Tell us kind of your journey in implants, because I know that you've had training and mentoring with one of the best in the field, Istvan Urban as well. So, give us a little bit of background about yourself, and then, we'll have a little discussion.
Sure. First of all, I'd like to thank you, Bob, for inviting me for this. I'm honored to be with you talking about implant dentistry, which is because I know it's a very good thing what you're doing. It's an honorable thing for sharing knowledge with colleagues. So thank you for inviting for me. It's a pleasure to be with you. Bit about me, my journey is, as you know, my name is Balaji. So I started implant journey like everyone, and from the placing 1-2 implants and feeling nervous, feeling anxious, keeping fingers crossed that it's going to work and going to be long-term success. Then I learned a lot from my own failures, and then start exploring to do some cases and things and learn from different mentors around the world. So I practice in Buckinghamshire, just north of Milton Keynes. My practice is mainly based on implants and hard and soft tissue augmentation. That's all I do at the moment. And I started an academy of soft and hard tissue augmentation, short way ASHA, where we do courses and stuff. But anyway, so today, we will, I would like to talk about where my journey started and then where I am now and where I'm going to go learning. Learning is every day. We are not going to be mastering everything. So yeah, we'll start discussion. It'll be great. Looking forward to that.
Fantastic. So, it sounds like you've had a similar journey to most of us where we learn from our failures. One of the things that people will hear me say time and time again, getting a good mentor is so underrated because you're going to pay one way or another. You either pay through your mistakes or you pay a mentor, and the mentor teaches you through their own mistakes. So it is basically an accelerated learning pathway. Exactly. So it sounds like in that context, that you and I have both been on a similar journey as well. Definitely. So, from my perspective, what I would very much like to discuss is we hear a lot nowadays that you only need one technique to graft. You only need one material to graft. And for me, that's very much not the case. I think there are certain parameters which are very, very important in grafting, but how you achieve those, there's a number of ways to climb a mountain effectively.
Yeah.
So when I'm looking at a case, I'm looking at how many defects has this got, i.e. where's the blood supply going to come from? For me, it's how am I going to stabilize the graft as well, and how am I going to get passive soft tissue closure? And then once the graft is healed, if you've got a passive closure and your keratinized tissue is not in the right place, how do you deal with that as well? So that doing a big graft, it has a knock-on effect on the soft tissue. And I think what a big issue a lot of people make is that they do nice grafts and then don't deal with the soft tissue and that, and then it then encourages more problems further down the line. The other thing that I think we should touch on as well is, particularly in anterior cases, this is something that Bhuta and I have already spoken about, is you are limited with regards to how much you can graft in any case by the interdental bone peaks. So I think we should also discuss the biological parameters of how much you can really technically graft.
Sure.
So, I'll leave it to you where you think we should start from, but let's start going through it one bit at a time.
Actually, the good point you made, Pav, is the biomaterials, right? We all think that one biomaterial is the best. Like we go on with the brand, like buying some people, like a cars. You go to BMW people and Mercedes people or a Porsche or a Ram. So it's not that. It's the most important thing is don't stick to the brand. Like you said, my experience from I'm talking from experiences. I used to stick to one biomaterial because the rep is very close to me, or I'm getting more support from them different ways. So then I made more failures because I tried to stick to one thing. Every biomaterial works within a parameter of clinical indications. That's what the main thing like you mentioned it is to understand the biology type of defect, and it lots involved type of bone we discussed just before we started, and type of soft tissue, very 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 important, and type of periosteum you're dealing with when you're doing a bone graft. All these things you need to gather information before you decide what type of biometal you're going to choose. You mean so any biometal do work in certain type of cases in certain type of patient. So what we are do most of us we are doing is okay. Oh, this biometal is easy to use and it works for somebody else. I'm going to try this. Of course, go ahead and try, but don't stick to that one technique because that technique is may work for that clinician because his clinical skills, his experience, and what he did does is maybe totally different from what I do and you do. So if you start with the biomaterial, start with after taking medical history and everything, type of defect, and what type of defect is it, soft tissue or a hard tissue or a combination. Then you think about is it a horizontal defect or a vertical defect. Then find about that, and then you mentioned about as well. If you're doing pre-maxilla aesthetic region, then you got to more careful about periosteum, how much you're going to advance the flap before you take a blade and make a incision. You think how much you need to advance your flap to cover your augmentation. So these are the things we need to think about. Then you think about the interdental bone, which is going to help us to build your vertical height. And we can talk about this for a whole day, yeah, which is really good. I don't mind spending the whole time. But again, uh, every step, if you see a case, don't jump in and make a decision straight away. Right, open the drawer, use this biomaterial. Sit back with all the information. Photograph. I take photograph of almost 99 time of my patient because I learned for my own benefit. Because I look at my photograph taken 2 3 years ago and I say, oh, this is my work. Okay, let's improve it. So it's self-learning, and then reflects and learn from the thing, and you can share with friends and colleagues, and possibly teaching as well. So take photograph of the pre-op, and then obviously CT scan, intraoral scanner if you have it. Then talk to colleagues. The other thing I like to mention, Pal, when I was started doing implants, which is time 10 13 years ago, we didn't have mentorship in UK. We had to make own mistakes, like you said, and then we learn from mistake. The good thing about now where we are, people like you and me and so many clinicians are coming out to help our colleagues to jump the hurdles with the help, so they don't have to same mistake you made and I made, and then it's better to use that sort of thing.
And
Uh,
I think in that context, we have the same mentality because I remember how painful it was making those mistakes and how much stress it was as well. And I'm not. I don't just keep going on about this because I'm touting for business. Because I'm very selective with regards to the people that I mentor.
yes,
Because I really push my mentees a lot. I really get them to think a lot, and some people don't like that, and that's fine. So it's important that and some people they're going to be fine without mentorship because they're going to stick to simpler cases. But you're right, is the scope of the field is changing, and the whole point is getting people to practice better and more safely. I want that, after my mentees have been practicing the same time that I have, I want them to be better than me. That's what everybody wants, right?
exactly. Because
Yeah.
I want my mentees to think before I start helping them. Because I can,
Yeah.
you can spoon feed them everyone, but
Yeah.
they are going to learn, and I want them to think, and I want them to come to me and say, "These are the thing I'm planning to do. What do you think different?" You know what? To be honest, by doing that, I learn a lot from them as well.
Yeah.
So it is
Absolutely.
both ways.
So one thing that's become abundantly clear is, particularly earlier on in my career, is you look at a case and you just go, yeah, there is a defect there. Now, what you said a few moments ago, it's a little bit more than just recognizing that there is a defect. So it's quite clear that the level of analysis that you're going into for these defects when you're planning to do grafting is quite a lot more than. I remember when I did my first course. All your basic implant courses, they have a half day on grafting, and it's normally put biomaterial in there and
Yes.
put a membrane on top and close it. It'll be fine. But when you start
Yes.
doing that clinically, and you put the biomaterial there, particularly if it's a xenograft or something like that, and you put a membrane on top and you go to close it and everything's moving underneath, and then when everything's moving underneath, how is it going to heal? And I think
Exactly.
this is a real problem that people need to understand is that is the grafting. It does take time to master, and as you said, you do need several different methods of doing it. So with regards to analyzing the defects more as well, does that alter how you approach cases? So, if you've got a certain type of defects, do you think to yourself, I'm going to use this type of approach, this type of biomaterial? Does it depend on the patient? Does it depend on the defects? What's going through your mind when you're looking at these different defects?
First of all, I mean, I assess the patient first, how much they're committed to it, to go through, because, like you said, they lost whatever the nature or God in a way provided to them, and then it's restoring back the giving the teeth implants is not only giving the implant and the crown on it. We are giving them a biotype back to soft tissue biotype back they used to be, or matching the neighboring adjacent biotype, and then the bone graft and everything. So I tell them, look, if you're coming to me, these are the stuff we are going to do. We do bone graft. We may need to do soft tissue surgery on the same time or 3 months time. There are several steps involved, and then your commitment need to be there, and patient commitment, patient compliance need to be there. Sometimes they say, "Come as oh, other dentists said, oh, it's one appointment, everything is done." Then so that sort of patient you got to be patient selection is very very be careful with that. Once you've done that, most of the time, by the time they come to me now, they know that, okay, this is going to be happening in here. So when I explain to them, spend a lot of time explain to them and why we're doing it. You know what? Most of the block, I'll be honest with you, is in our dentist head, not the patient.
Yeah,
Do you mean
yeah,
when patient comes to you and say, "Oh, it's going to take you 12 months to have a tooth," and explain to them why the 12 months, they say, "Oh, it's fine." But we are the one thinking, "Oh, 12 months, it's not going to take. I'm not going to do it." That's what the problem is. Once I explain to them and explain, I use some analogy for explaining to them why we do it. Then they say, "Okay, fine, fair enough." And then the other thing I would say, failure happens all the time, all right? And then it's
yeah.
okay, things go wrong and failure is okay, and it's nothing wrong with it. We are not god or anything. We are human. We doing a technique which worked 90% of the time. 10% patient do have failures.
Yeah, I think that's important to know that just as we can have failures with implants, absolutely we can have failures with grafting. And it may be a soft tissue failure, it may be biomaterial integration failure, it may be a combination type failure.
Yep,
There is nothing wrong with that. We have to stop beating ourselves up about it.
exactly.
Something that you and I were discussing just before we started recording, which is something else that Bill Schaefer and I have spoken about on a podcast recently, is we are noticing that patients are coming in, that their bone is just getting softer, and that the metabolism of the bone's changing. So we
Yes,
have to factor that into our treatment planning, whether we're leaving patients longer, whether we are doing blood tests beforehand. We need to be considering this type of stuff.
exactly. Yeah,
So yeah, accept the fact that even the simple cases you may get failures, but even the more complex cases you may not have a failure. That's the nature of dealing with biology, right?
right. That's right. Yeah,
Yeah.
you're right. Patient selection, do everything right, everything you do it, but still things can go wrong. So the best thing to do is to be like prepared for it, and then and managing a complication. That's another big topic. We can talk about it as well if we have. Yeah.
So when it comes to when it comes to grafting, what are the for me there's three or four parameters that are important in grafting. How you achieve them, there's several ways to achieve them, but what would you say are the main things from me, from my point of view? And this is something that I learned from Howie Gluckman when I went on his courses, is what's the size of the defect? So you're trying to figure out where the blood supply is going to come from. The second one is how are you going to stabilize the graft? The next one is keeping the pressure off the graft, because if you've got pressure on the graft, it's not going to heal. And then the fourth one is, okay, once that's all integrated, what do you do with the soft tissue? So have I missed anything? Is that your thought process as well? Tell us a little bit more.
You're right. This, I said the first one is the defect, size of the defect, type of the defect. As mentioned, how soft tissue, hard tissue, combination, vertical, horizontal, or combination of those, all those things. Then what I look for mainly is this: what type of soft tissue that point they have it with pre-op, and do they have a thin biotype, or how deep is the vestibule to advance the flap? What type of periosteum they have? Is it a scarred periosteum, or let's say the patient had a episectomy several times and root canal treatment, which had a sinus in it on the one of the tooth. Those patients are quite hard to advance the flap. So then we need to realize how wide you're going to go, or is there any other way of you going to advance the flap for you to close the graft for you? So many things like that you need to first soft tissue, flap design. I would go think that once you have raised the flap and everything, then you look at the when you put the graft. You are right. You need to fix the graft in place by either what type of, if you're using a block graft, then you got to have screws. You shouldn't have any movement on the graft. Once you have a small tiny movement, then you lost. I have done it in the past. You like you said, put a biomaterial or whatever it is, and tuck the membrane on the top of it, and you try to close. You can't close. Then I made an incision, bleeding, bleeds like anything as you know. Then my poor nurse tried to help me, and he tried to aspirate the bleeding, but she aspirated all the materials and everything off.
Yeah.
Yeah, I mean, it's happened so many times in my own thing. So
Yeah.
then you got to release the periosteum in such a way it doesn't bleed, but still you're able to advance it. So then you suturing technique depends on what type of membrane you're using. Then you got to decide: are you going to have a primary closure or a bilayer closure? All those things we do that. Then once you've done that, your soft tissue, like you said, mucociliary junction will be quite moved at different places. Then you got to think about the soft tissue after that. Sometime on the same day of graft as well you can do. So there's so many steps. Each and every step is quite important to get the graft going when working for you and the patient.
So probably the three best grafters on the planet that I know, all for slightly different reasons, is Prof. Kuri,
Yes.
Prof. Urban,
Yes.
and Ole Jensen. Okay, these guys can pretty much graft anything, right?
Exactly.
There's a lot of people who say, the Curry plate technique is absolutely superb, and it is. I've used it; it is really incredible. I've also seen the results of Prof. Urban's work as well. I think what we should do is let's break those down a little bit, right?
Sure.
So, why do I think that both of these techniques work so well? Because these guys can get really big vertical grafts, right? Is they are respecting all of the principles that we've just discussed, right? They are getting passive soft tissue closure.
Yes.
And what they're doing is they're really immobilizing the graft underneath. They're just using different techniques to do it. So Prof. Curry uses his autogenous plates, and
Yes.
Prof. Urban uses his sausage technique, which is just a stuff PTFE membrane. But the whole point is the graft is being significantly immobilized underneath.
That's right.
Ole Jensen, he uses a lot of osteoperiosteal flaps, so he will split ridges. It's absolutely stunning work, and he maintains as much blood supply to these grafters what they possibly can.
Yeah.
So this is why I want people, whoever's listening to this, whether it's 2 people, 20 people, it doesn't matter. If we can help 1 or 2 people, that's great. It's normally a bit more than that. I'm just giving an example. Is I want you to think about is that it's not just the biomaterial. That's what we're both discussing now, right? It's not just one technique. There's several techniques to do it. What you need to understand is the principles behind it. So when you are reading a textbook on grafting, when you are attending a course on grafting, is you need to understand the principles of the technique behind it. right? So that is my perspective.
Exactly.
Have I missed anything there? Am I wrong on that?
No,
Is,
no, you're right. 100% right. Because I done the whole curriculum of Prof. Corey. I done the whole curriculum of Istuan as well. So I've been doing all the courses and worked with Prof. Corey for a long time. I worked with Urban as well. So the basic principle, you're right. The graft should be stable. If you go to orthopedic surgeon, if you break your arm, they put your arm in a sling for 6 weeks or whatever, 12 months, or put a plate on it because their aim is to keep the broken bone in place, not even a micro movement. The
yeah,
same principle we are using in patient's mouth, and where the
yeah,
loads of bacteria, loads of saliva, loads of movement, loads of changes happening constantly, and that's what we need to aim to do. We are not different from orthopedic surgeons in certain
yeah,
extent. You mean so when you do a graft, you make sure it's stable. When you talked about the sausage technique, the most important thing Istuan told me was when you do a sausage technique or a PTFE membrane, once you put a pin or a suture, put your finger on the top of the sausage or a PTFE membrane, press. If any movement, even micro movement, you won't get bone.
yeah,
Make sure you stuff more and more and more bone in it. And same with Prof.
yeah,
Cole. Put so many he used micro pins, and I used the same thing, micro pins he asked us to use. So the
yeah,
micro pins need to be everywhere so that the bone doesn't move, and then the
yeah.
passage comes in. No pressure, like you mentioned, on the graft, no denture on the top, or no bridge pressing on the graft.
So I don't know whether you're aware. I've got a friend of mine in Italy called Enzo Fotti,
Yeah.
and I met Enzo when I did Roberto Rossi's course on
Okay.
cortical laminar technique,
Laminate
and
technique.
he used fibrin glue, and they
Yes.
mixed this fibrin glue, they
Yeah.
put it into place, and then they glued the cortical laminar on it. They wait for it to set 10 minutes, and he said to me, Pav, he said, just press that. He said, see how secure it is. You could. It was super glued into place. It did not move. So
So,
going back to that is you are completely immobilizing the graft. Again, it goes back to basic principles of healing, right?
that's
So
exactly.
it is really important to understand. What I would say is Albrechtsen did a really good study where he looked at the angiogenesis into a block graft versus particulate graft.
Yes.
Okay, the angiogenesis into a block graft is 0.05 millimeters per day.
Right.
Okay,
Yes. Yeah.
the angiogenesis into a particulate graft is zero point 0.5 millimeters per day. What does that mean? That means particulate grafts heal 10 times faster than what block grafts do.
Yeah.
That's why quite often block grafts, when you put them in place, you come back later, you go to drill into it, it just falls off. And this is one of the reasons why Prof. Curry's technique works, is because he's taking autogenous bone, but instead of using it as a block, he makes it particulate. But it's the same reason why Prof. Urban's technique works as well. So again,
Yes.
it's understanding that basic principle is you are allowing the body to heal. So you need that lack of mobility, you need that completely stable situation, but you need that blood supply regenerating really quite quickly. The quicker it regenerates, the better the healing you're going to get.
That's right. That's right. And if you look at Prof. Corey's technique, he uses autogenous bone and autogenous thin layer of cortical plate. It is like less than 1 millimeter. You can see through. That's what he says. You got to look at the light. Should be able to see through that. So it acts like a membrane, basically. The cortical plate, what he uses. The rest is particulate bone. He savings from the block, and he just puts in, and that's what it works. And it works beautifully well for him, and
Yeah.
beautiful technique.
Okay, so I mean, there's some. I'm enjoying this conversation, right? So we've talking about a few of the parameters involved with regards to grafting. We've gone back to basic principles on this as well. So let's say you've done a large graft. It's now at the point where the graft seems to be taken quite nicely. Oh, before I mention is, what is your average healing time for a graft? Is it dependent on the size of the graft? Is it dependent on the biomaterials that you use? Is it dependent on the patient age and on their health as well? Give us kind of like, because for me, it's not as simple as, oh, use this biomaterial, wait 12 weeks, you're fine. There's so many factors involved. What are your thoughts on it?
No, that's a good question. Again, it changes from patient to patient, defect size to defect size, and the type of biometal you use. Okay, let me say if it's a patient, let's take one patient, and if I'm doing a biomaterial with a membrane, which is a collagen membrane, like let's say membrane resorbs in 6 weeks to 8 weeks, still I don't go back and open for at least minimum 4 months. If I use membrane which is going to last longer, let's say it's going to stay there for 4 to 5 months, like cross-linked collagen membrane, then I won't do for 6 months. If I'm using a PTFE membrane, dense PTFE with no perforation in it, then definitely 9 months for that. But if I'm using a PTFE, which is now new one is RPM, which has got a perforation to it, then I would, depends on the soft tissue how it is healing. I would choose 6 months to 9 months, between 6 to 9 months. So 4 months, 6 months, 6 to 9 months sort of thing. Depends on the what type of membrane I'm using and what type of biometal I used.
Okay.
If it's a vertical, if it's vertical, definitely minimum 6 months.
Yeah.
Sorry. But anything other than that, maybe 4 to 6 months.
So, what about how do you deal with the soft tissue? So, once it's all healed, let's assume that the graft's healed underneath. What are your go-to principles for dealing with soft tissue?
The basic principle for soft tissue for me is what I learned from my mentors is I would like to have minimum 2 millimeter thickness, 360-degree all around the crown, both horizontal and vertical. But this is particular. I'm talking about graft cases, not for straightforward implants. So if I have a graft, any type of graft, any biometal I used, then I would look for at least minimum 2 to 3 millimeter of chitinized mucosa or thickness of the mucosa and around the crown or a bridge, both horizontal thickness and vertical thickness.
Yeah.
So if it's not there, then I choose, depends on what type of soft tissue graft I'm going to do. It could be starts from free ginger graft, or it can be just classical connective tissue graft, or it could be just deepithelialized zucchini type of graft. Yeah, so many things we can choose. But the basic principle is 2 millimeter every side.
Yeah, and I think Linkovicius has demonstrated that really quite clearly on a number of occasions. That not only do you need an adequate band of soft tissue thickness, you need an adequate thickness of soft tissue as well.
Yeah.
I think is if you don't have that, you will have problems. Maybe not in the short term, but certainly medium to long term. And I think it goes back to what you were saying towards the beginning as well, is that, it all comes down to your confidence and how you convey it to patients. Is if you convey things to patients with confidence and you say to them, look, this needs to be done, and you should be charging for this as well. It shouldn't be free of charge. This is complex work. Is that can be the difference between an implant starting to develop problems after 5 years versus an implant being absolutely fine for 20 years. So it's it is a very important aspect, soft tissue.
That's the thing, like we talked about, the clinician should be confident enough to do the procedure plus charge for that. We don't do because I'm worried about it. I don't want to charge it because it's your time and your skills you're doing it. As I said to you, things can go wrong. It can fail. Sometimes when failure happens, I really take it to my heart and I quite very affects me. And I speak to my brother. He's a cardiac surgeon, right? And I always ring him purely because I tell him I lost tooth, and he says, my patient died.
Yeah.
You know what I mean? That's the difference. He says, yours says you lost tooth, but my patient died. So that's a big difference there. So I don't, fine, okay. So it's we're dentists, okay? We give them so much things to the patient, but still, patient can survive, patient can live.
Yeah.
There are so many other surgeons in the world, or anybody's, they do a bigger job than us. So
yeah, I think that's true. As soon as I think to myself, I'm starting to get really good at implants, then I see some of the crazy stuff some of these MaxFax consultants are doing with oncology cases, and you feel like a complete novice again. I know a colleague in America who's a MaxFax consultant. And he was like, "Oh yeah, I did a hemimandibulectomy." He said, "I got rid of a patient's mandible from here to here." He said, "The day that I did that, I put implants into the patient's shin, into the tibia." He said, "Went back 6 months later, cut out his tibia, rebuilt his mandible." He said, "This is the post-op." He said, "Doesn't look perfect." And I was looking at it going, "Wow, I wish my implants looked like that." But you did it from the leg.
That's what I'm saying. We, of course, we do a great job. Don't get me wrong. We are amazing surgeons. Our dentistry is one of the best profession. I wish, I'm so happy. We are fortunate. We are fortunate. But again, there are some professions, like say, my friend is Max Function Consultant Pool. He operates on all the cancer patients, and when I look at it, it makes me humble. Like, oh, come on,
I
guys.
think that's what it is.
I mean,
I think what we're trying to express to those listening is when things go wrong, don't beat yourself up about it too much, right? That's what it is more than anything else. So, I mean, you've had some pretty extensive training in grafting. What have you seen that's been like, wow, this is incredible? Because you must have seen some awesome stuff. So.
But I have so many, so particularly, I've done so many courses, and then two people in hard tissue augmentation, which stands out for me, is Prof. Corey and Prof. Urban. And both are, their own way, they're fantastic. They're amazing. Um, and then I use a lot of urban technique because it's slightly, for me, it's not the technique. It's for me as a clinician, me alone working here, it works so easy for me. Prof. Core technique is fantastic. But if you have a colleague, like for example, you and me working together, it makes it easy for me. But there are so many my colleagues, my friends do just Prof. Core technique. It works beautifully. And I mix and match, depends on the cases, depends on
Yeah.
severity, and depends on how much I'm going to cope with that particular case. So I mix and match the thing. So these two guys are in hard tissue regeneration, fantastic. There are
That's fantastic.
and another thing person I would like to mention is the Professor Zuccoli is soft tissue, and he is gives open my, like, I like, wow, these are things you can do. Now I'm quite recently I'm started doing more of soft tissue. Yeah, I'm doing more of soft tissue work. Sometimes, like, even normal implants I do more soft tissue there, and the results you're getting, papulas and stuff. I sometimes I used to think, oh, this patient is going to be black triangle, but by doing this
Yeah.
different technique, you can get papula. You can develop.
Yeah.
Yeah, you can't guarantee it, but yes, you can. So
Yeah, I mean, one of my favorite techniques because it's so simple, but it's so exquisite. Is the Palachi flap.
oh yes, I
Patrick Balaji flap is just it's
that's good.
stunning technique.
Exactly.
I don't know whether you've seen as well. There's another colleague in France, Anan Simon Pieri,
Yeah, I have.
and I'll tag you in some of his work, but you'll just look at it. You'll just look at it and go, that's just beautiful work.
Yeah.
I remember looking at some of his cases and thinking, dude, you can't do that. It's not going to be stable.
Look forward to
And I said to him, I said, what's this like at 2-year follow up? And he goes, what do you mean? He goes, the photo that you've just seen is a 10-year follow up, and you just go,
oh, that's amazing.
well, my mind's absolutely blown. So, I mean, there are certainly a lot of people out there that we can continually learn from, and I'm continually looking to learn and improve as well. And in fact, it's something that I've said to you is I want to attend your course. So I'm aware that we've covered quite a lot already. So for those listening, could you tell us a little bit more if anybody wanted to learn more about your course? What's the best way to get in contact? What's the best way to learn about that?
Sure.
And what do you cover in the course?
No, okay. What my course is mainly, the ethos of my course, Pav, is to we can do the techniques which we used to think we can't do it. Right. That's the ethos I want to pass it to this one on any podcast I do, because basic principle is if I can do it. I was everyone like you. I was not Max Price trained. I was simple general day-to-day dentist. But what I was trained and put my mind and time to learn things, and I'm getting a lot of good success. So what I want to pass message is to everyone can do it if you put your mind and time and develop your skills. So my course is from ASHA, the Academy of Soft and Hard Tissue Augmentation, is to tell everyone, whoever comes to the course, what we cover is the type of defect and all those things we talked about, what biomaterial works for that particular type of defect, how you do it, basic principles, why you do it, not only how you do it, why you do it, and if this happens, what would you do next, and then what type of soft tissue you would choose for this type of defect. So stage by stage, don't go and rush into everything in one time. Stage by stage, depends on the defect you learn. After the course, you are not, most of the time, I've been to courses to come back and say, oh, where do I start? How I'm going to do it? But this one is we are having a group of clinicians who done the course. We are going to work together and mentor, like you said. We have a
Yeah.
faculty of people who will be one in North, one in Midlands, one in down South, whatever. Doesn't matter. According to skills, they will start mentoring the new people coming in. So idea is everyone can do up to their skills. Not everybody could do a vertical augmentation. Not everybody could do that. But even if 20% of people does it, it'd be great. And this
Yeah.
technique works, and it works. So that's what I want to do with my course, and this is what I will teach: soft tissue, horizontal, vertical augmentation using different.
Yeah. And I think it's the same as everything, is once you understand the principles better,
Yes.
A, it will make your core work better,
Yes.
but B, you'll start to understand, actually this is outside of my competency. So what it will do is if you start here,
Yes.
you'll end up 80% of your work better, and you'll know that 20% you don't want to touch because you don't do it often enough. You
That's
can't
right.
build up muscle memory. This is what I always say: muscle memory, muscle memory, muscle memory. Okay. When I first started at Evo Dental, it used to take me 4 or 5 hours to do a dual arch.
Exactly.
I can now do a dual arch in 2.5 hours.
I'm sure.
I didn't get that overnight. I got there doing it every single day for nearly 2 years. That's why I can do a dual arch in 2.5 hours now.
Exactly.
Right?
Exactly. My first case, my presentation case for is 2 course was 6.5 hours. It's just now I can do the same course in an hour and a half or 2. It took me 6.5 hours, bilateral sinus guard with vertical both sides. And it just took me 6.5 hours. I had to video it, to present it, and all those things. But now I can do in an hour and a half, maximum 2. The more you do it, like you said, it comes to you. You will learn. Yeah, that's right.
Yeah. Well, thank you so much for joining me on an evening. I'm aware it's 5 to 9.
No, it's pleasure. Honestly,
So Titanium Nerds, thank you very much for tuning in. And as I said, it's always a pleasure having guests like this on who are prepared to give up their evenings. It's been an absolute pleasure. So reach out to Balaji and if you're interested in his course. I know a lot of dentists in the UK are already aware of you. And it's certainly a course that's on my radar as well, my friend. There's 2 courses I'd very much like to do. One is Buta Ubi's soft tissues course because Rudy's been on it and he absolutely raves about it. And Buta's a nice guy. I've spoken to him before and I've seen his work. I want to do that. And yours is the other course as well. I'm relatively confident in my grafting skills, but as I said, the moment we think to ourselves, I know enough, we stop our own progression. So we have to constantly be learning, constantly upping our own game.
That's right. What I do, I will give my email address and stuff if you want to post it at a later stage. If somebody wants to get in touch with me with their own cases, I'm more than happy to help them.
Well, what we'll do is when I upload it to the Facebook page, send me the link, and I will put the link in there as well, and I'll do the same in the LinkedIn and the Instagram, and I'll tell my editor to do the same when he puts it onto YouTube as well. So we'll try to put a link out there for everybody. Okay?
No worries. Thank you very much, and thank you. It's pleasure. And I couldn't believe it's an hour gone, and I go on for another hour easily if you want to. But yeah,
what happens when you're a titanium nerd, right? So start talking titanium, and the time just passes. So thank you very much, everybody, for listening. Okay.
Thank you, pal.